Welcome back to the deep dive. Today we're looking at something, something you're doing right now without even thinking about it, breathing.
That's right. It seems so simple, doesn't it? Just in and out.
Exactly. But behind that simple action is this, incredible system, the human respiratory system. And that's our mission for this deep dive, to really unpack how it all works.
We'll look at the structures involved, how the air actually moves, what controls it all.
And some surprising ways it adapts, or sometimes struggles. You'll get a really solid understanding, hopefully with a few aha moments about, every single breath you take.
It really is amazing. And it starts with why we breathe, doesn't it? Our bodies, they just completely depend on the outside world, especially for oxygen.
Right. You hear people say you can last weeks without food, days without water.
But oxygen, only moments. It's that critical difference. Every single cell needs that constant supply.
So bring oxygen in. But it's a two-way street, isn't it? We also need to get rid of stuff.
Exactly. When our cells use oxygen, they produce waste, mainly carbon dioxide, and we absolutely have to get that out.
Okay. So how does the body manage this exchange?
Well, it's really a four-part process. First is just moving air in and out of the lungs. Breathing, we call that pulmonary ventilation.
Simple enough. Air in, air out.
Then, once the air is in the lungs, oxygen needs to get into the blood, and carbon dioxide needs to get out of the blood and into the lungs. That's step 2, external respiration.
Okay, so those first two, ventilation and external respiration, that's the respiratory system's main job.
That's its direct responsibility, yes. But here's a really key point: it can't do it alone. The third step, actually transporting those gases around the body, that's all down to the cardiovascular system.
So the heart and blood vessels take over.
Completely. Blood carries oxygen from the lungs to the tissues and brings CO2 back. And then the fourth step, internal respiration, happens at the other end. Oxygen moves from the blood into your cells, and CO2 moves out of the cells into the blood.
So it's a real team effort. Respiratory gets it in and out of the lungs, cardiovascular moves it around.
Precisely. And if either one fails, the cells starve of oxygen. It's also worth just quickly mentioning that when people talk about cellular respiration, that's different. That's the energy production inside the cells themselves, not the job of this system.
Got it. A crucial distinction. And besides just gas exchange, the respiratory system has other jobs too.
It does, because air passes through it. It's essential for your sense of smell and, obviously for speaking. You can't really talk without moving air.
Try holding your breath and talking doesn't work. Okay, let's start that journey. Where does the air first come in? The upper airway.
Exactly. Starting with the nose and the paranasal sinuses. We often just think of the nose as, part of our face.
Right.
But it's incredibly sophisticated. It's the main airway, yes. But it also warms and humidifies the air coming in, filters it, acts as a resonating chamber for your voice. Oh, and holds your smell receptors. 5 key jobs.
How does it warm and humidify so well? Especially like on a freezing day, it feels instant.
It's clever engineering. Under the surface of the nasal passages, there's this rich network of tiny blood vessels, capillaries. When cold air comes in, warm blood rushes through them, heating the air really quickly.
And the moisture
comes from the mucus lining. It's naturally moist. And that mucus is also key for filtering, trapping dust, pollen, microbes. It even contains enzymes like lysozyme that fight bacteria.
So it's filtering and disinfecting right at the entrance. What about, when your nose runs on a cold day? Is that just excess mucus?
It's partly that, but also the tiny hairs, the cilia that normally sweep mucus back towards your throat, they get sluggish in the cold.
Okay.
So mucus can build up a bit, and you also get condensation from the water vapor in your warm breath hitting the cold air, so it drips.
Makes sense. And that's why nosebleeds are common too, right? Those blood vessels are near the surface.
Very close to the surface, yes. Makes them easy to damage.
Okay, moving back from the nose, we get to the pharynx, the throat.
Right, the pharynx. It's sort of a funnel shape connecting the nasal cavity and mouth down towards the larynx and esophagus. It's a shared space, really.
Shared. For air and food.
Exactly. The upper part, the nasopharynx, is usually just air. But the lower parts, the oropharynx and laryngopharynx, handle both air on its way to the lungs and food on its way to the stomach. There are mechanisms to make sure they go down the right pipe, of course.
And sometimes things can go wrong there, like swollen adenoids.
Yes, the adenoids are lymphoid tissue in the nasopharynx. If they get infected and swell up, especially in kids, they can block the nasal passage, forcing mouth breathing.
Which means you bypass the nose's air conditioning system.
You got it. The air doesn't get warmed, filtered, or humidified properly.
Okay. Down from the pharynx, we reach the larynx.
The voice box.
The larynx. Three main jobs here. Keep the airway open, act as that crucial switch between air and food, and, of course, produce your voice.
That switching part is amazing. The epiglottis, that little flap. It's often called the guardian of the airways, and for good reason. When you breathe, it stands upright. But when you swallow, the whole larynx moves up and the epiglottis folds down like a lid, covering the entrance to the trachea.
So food slides over it and down the esophagus instead.
Exactly. And if anything other than air tries to get past it, maybe a crumb or some liquid, it triggers a really strong cough reflex to propel it back out.
And the voice part, how does that work?
Inside the larynx are the vocal folds, or vocal cords. When you exhale and want to speak, muscles adjust these folds, and the air rushing past them makes them vibrate.
Like guitar strings?
Sort of. The tension and length determine the pitch. Tighter and shorter is higher pitch, and the force of the air determines the loudness.
So when you get laryngitis,
the vocal folds are inflamed and swollen. They can't vibrate properly, so your voice gets hoarse, or you might lose it altogether for a bit.
Right. Okay, past the larynx, down we go into the trachea. The windpipe.
The trachea. It's a pretty flexible tube, maybe 4 or 5 inches long, and it has these characteristic C-shaped rings of cartilage.
C-shaped. Why not full rings?
Ah, good question. The open part of the C faces backwards, towards the esophagus, which runs right behind it. This allows the esophagus to expand a little when you swallow a larger piece of food.
Makes sense. And the cartilage keeps the trachea from collapsing.
Exactly. It keeps the airway open. But there's also a muscle, the trachealis muscle, connecting the open ends of those C-rings. It does something pretty amazing, too.
Which is?
When you need to cough forcefully, that muscle contracts, narrowing the trachea's diameter. This makes the air rush out much faster, like putting your thumb over the end of a hose pipe. It can reach speeds of 100 miles per hour.
Wow. To blast out irritants.
Precisely. It's a powerful clearing mechanism. And it also underlies why the Heimlich maneuver works, using pressure to force that air out.
Okay. After the trachea, it starts branching out. The bronchial tree.
Yes, the trachea splits into 2 main bronchi, one for each lung. An interesting little detail. The right main bronchus is wider, shorter, and more vertical than the left.
Does that matter?
It does if you inhale something you shouldn't, like a peanut or a small toy piece. It's more likely to end up in the right lung because of that straighter path.
Good to know. And then these bronchies keep dividing.
They divide again and again, about 23 times in total, getting smaller and smaller, like branches on a tree, leading eventually to tiny little tubes called bronchioles.
And the structure changes as they get smaller.
Significantly. The cartilage rings gradually disappear, the lining changes, and importantly, the amount of smooth muscle in the walls increases relative to the diameter.
Smooth muscle.
Yeah.
So they can constrict.
Yes, and that's really important. Unlike the trachea and larger bronchi held open by cartilage, these smaller bronchioles can change their diameter, which affects airflow resistance. Think about asthma, that's often constriction of these bronchioles.
And smoking damages this area too, right? The cilia.
Terribly. Smoking paralyzes and eventually destroys those tiny cilia that sweep mucus up and out. So mucus builds up, leading to that chronic cough. It becomes the only way to try and clear the airways.
Right. So all this branching, all these tubes, they're just conducting the air. Where does the actual gas exchange happen?
We finally arrive at the respiratory zone. This starts with the tiniest bronchioles leading into the alveoli. These are the microscopic air sacs.
They're like tiny balloons.
Exactly. Millions of them. About 300 million in a typical adult lung. Think of them like tiny grapes clustered together in alveolar sacs.
The 300 million hour. That must create a huge surface area.
It's staggering. If you could spread out all the alveoli in your lungs flat, they'd cover an area of about 90 square meters. That's roughly 40 times the surface area of your skin, all packed inside your chest.
Incredible. And that's where the oxygen gets into the blood.
Right across the wall of the alveolus and the wall of the capillary running alongside it. These 2 incredibly thin layers form the respiratory membrane. It's unbelievably thin, about half a micrometer, 15 times thinner than tissue paper.
Wow. So oxygen and CO2 can just diffuse across easily.
Very easily and very quickly. And there's another crucial element here. Special cells in the alveoli, type 2 cells, produce something called surfactant.
Surfactant. You mentioned that it helps prevent collapse.
Yes, it's like a detergent. The inside of the alveoli is moist, and water molecules tend to stick together, creating surface tension. This tension would naturally try to pull the tiny alveoli shut, especially when you exhale. Surfactant reduces that surface tension, making it much easier to inflate the lungs and keeping the alveoli from collapsing.
So it keeps those tiny balloons from sticking together when they deflate.
That's a great way to put it. And your lungs also have their own cleanup crew working down there too.
Oh yeah? What's that?
Alveolar macrophages. These are immune cells that basically wander around the surfaces of the alveoli, gobbling up any dust, bacteria, or debris that made it that far down.
Constantly cleaning.
Constantly. We swallow millions of these macrophages every hour without even noticing.
Amazing. Okay, so that's the microscopic level. What about the lungs overall and how they sit in the chest?
The lungs themselves are sort of cone-shaped, filling most of the chest cavity, except for the space taken by the heart. The left lung is a bit smaller than the right because the heart tilts slightly to the left. It has a little indentation called the cardiac notch.
And they're wrapped in something. The pleurae.
Yes. Each lung is enclosed in a double-layered sac called the pleurae. There's an inner layer stuck to the lung surface and an outer layer stuck to the inside of your chest wall and diaphragm.
And there's fluid between them.
A very thin film of pleural fluid in the tiny space between the layers. This fluid does two things. It lubricates, letting the lungs glide smoothly as you breathe.
And it also makes them stick together, right? Like wet glass slides.
Exactly. That's the perfect analogy. The surface tension of that fluid makes the two layers adhere very strongly. They can slide past each other, but you can't easily pull them apart. This effectively couples the lungs to the chest wall.
So when your chest expands, the lungs have to expand with it.
Precisely. And this adhesion maintains a slightly negative pressure in that pleural space relative to the pressure inside the lungs. This negative pressure is essential for keeping the lungs inflated.
What happens if you lose that negative pressure? Like if air gets into that space?
That's a pneumothorax. If air enters the pleural cavity, either from outside through a chest wound or from the inside if the lung itself is punctured, that negative pressure is lost, and the natural elasticity of the lung causes it to recoil and collapse. That's called atelectasis.
Serious stuff. Okay, so we have the structure. How does the air actually get moved? The mechanics.
It all comes down to pressure differences, governed by a fundamental physics principle, Boyle's law.
Boyle's law. Sounds technical.
It's actually pretty simple. It just says that for a gas in a closed container, if you increase the volume of the container, the pressure of the gas inside decreases. If you decrease the volume, the pressure increases. P1V1 equals P2V2, basically.
Okay, volume and pressure are inversely related. How does that apply to breathing?
Your chest cavity is the container. When you inhale, your diaphragm contracts and flattens down, and your external intercostal muscles pull your ribs up and out.
So the volume of the chest cavity increases.
Right. Big increase in volume. Boyle's law says this causes the pressure inside your lungs, the intrapulmonary pressure, to drop slightly below the pressure of the air outside your body, atmospheric pressure.
And air flows from high pressure to low pressure.
So air rushes in. That's inspiration. It's an active process requiring muscle contraction.
And exhaling, expiration.
Quiet expiration is mostly passive. The muscles relax, the rib cage lowers, the diaphragm domes back up, and the natural elasticity of the lungs makes them recoil.
So the volume decreases.
Volume decreases, pressure inside the lungs rises above atmospheric pressure, and air flows out. No active muscle work needed for quiet breathing out. Force expiration, though, like blowing out candles, is active. You use abdominal muscles mainly.
Got it. Active in, passive out, mostly. Are there other things affecting how easily the air moves?
Definitely. 3 main physical factors. First is airway resistance. Just like water flowing through pipes, air flowing through your airways encounters friction.
More friction means harder to breathe.
Yes. But interestingly, the main site of resistance isn't the tiniest airways, the bronchioles. It's actually the medium-sized bronchi.
Really? Why that?
Because although the individual tiny airways are very narrow, there are millions of them in parallel. So the total cross-sectional area down there is huge, meaning overall resistance is low. The medium bronchi have fewer parallel paths.
But those bronchioles can cause problems, right?
Yeah.
With their smooth muscle.
Oh, yes.
Yes.
Because they lack cartilage support and have relatively more smooth muscle, they can constrict significantly, like during an asthma attack or due to irritation and dramatically increase resistance. That's when breathing becomes very difficult.
Okay, resistance is one factor. What else?
Alveolar surface tension. We talked about this with surfactant. The water lining the alveoli creates tension that constantly tries to collapse them.
And surfactant fights that.
Exactly. It reduces the surface tension, making the lungs much easier to inflate. Without enough surfactant, like in premature babies with infant respiratory distress syndrome, IRDS, inflating the lungs takes enormous effort.
Right. And the third factor?
Lung compliance. This is basically how stretchy or distensible your lungs are. Think of it as the ease with which they expand.
So high compliance is good, means they stretch easily.
Correct. Healthy lungs normally have high compliance thanks to their elastic tissue and the low surface tension provided by surfactant. But diseases that cause scarring or fibrosis or even just the stiffening of the chest wall with age can decrease compliance.
Making it harder work to breathe.
Much harder and requiring more energy.
So doctors can actually measure how well the lungs are doing all this, moving air.
Yes, using spirometry. It measures different respiratory volumes, like how much air you move with a normal breath, tidal volume, how much extra you can inhale, inspiratory reserve, how much extra you can force out, expiratory reserve, and how much is always left, residual volume.
And these help diagnose problems. What about dead space? I've heard that term.
Good point. Anatomical dead space is the air that fills the conducting zone, nose, pharynx, trachea, bronchi, the parts that don't do gas exchange. It's about 150 milliliters, roughly.
So some air you inhaled never reaches the alveoli.
Exactly. It just fills those pipes and gets breathed out again. This is why slow, deep breaths are more efficient for getting oxygen into your blood than rapid, shallow ones.
Because a smaller proportion of each breath is wasted in dead space.
You got it. More of the fresh air actually gets down to the alveoli where it can be used.
Makes total sense. Okay, let's get to the core process, the actual exchange of gases. How do oxygen and CO2 move between the air and the blood and between the blood and tissues?
It relies on two more fundamental gas laws. First is Dalton's law of partial pressures.
Okay.
It just means that in a mix of gases, like air, the total pressure is the sum of the pressures exerted by each individual gas. And the pressure of each gas, its partial pressure, is proportional to how much of it is in the mixture.
So air is mostly nitrogen, then oxygen, then a tiny bit of CO2 and other gases. Each pushes with its own pressure.
Exactly. And the second law is Henry's law. This one says that the amount of a gas that will dissolve in a liquid is directly proportional to the partial pressure of that gas above the liquid.
Like a soda can. CO2 dissolved under pressure.
Perfect example. When the can is sealed, the high pressure of CO2 above the liquid forces lots of CO2 to dissolve in the liquid. Open the can, the pressure drops, and the CO2 comes out of solution fizz. Temperature matters too. Gases dissolve better in cold liquids, which is why warm soda goes flat faster.
How does this apply to breathing?
Well, oxygen and CO2 have to dissolve in the fluid lining the alveoli and in your blood plasma. Henry's law tells us the amount dissolved depends on their partial pressures. Crucially, CO2 is about 20 times more soluble in water and plasma than oxygen is. Nitrogen is barely soluble at all.
So even if the pressure difference isn't huge, lots of CO2 can move into or out of solution easily.
Precisely. This solubility difference is very important for efficient gas exchange. And these laws also explain things like the bends in diverse nitrogen dissolving under pressure at depth, then bubbling out dangerously if they surface too fast, or hyperbaric chambers forcing more oxygen into the blood under high pressure.
So the actual exchange, external respiration in the lungs, internal in the tissues, it's all driven by these partial pressure differences, diffusion down the gradient.
Simply put, yes. In the lungs, the partial pressure of oxygen, PO2, is high in the alveolar air, around 104 millimeter Hg, and low in the blood arriving from the body, around 40 millimeter Hg. So oxygen flows rapidly from air to blood.
And CO2 is the opposite.
Right. Partial pressure of CO2, PCO2, is higher in the incoming blood, around 45 millimeter Hg, and lower in the alveolar air, around 40 millimeter Hg. So CO2 flows from blood to air. Even though the pressure gradient for O2 is much steeper, roughly equal amounts are exchanged because CO2 is so much more soluble.
And that huge alveolar surface area helps make it super efficient.
Absolutely essential. But if that membrane thickens, like with pneumonia or fluid buildup from heart failure, the diffusion distance increases and gas exchange gets impaired.
Now, does the body try to match the airflow to the blood flow in different parts of the lung?
It does. It has this amazing local autoregulation called ventilation-perfusion coupling. It tries to match airflow, ventilation, to blood flow perfusion.
How?
If an area of the lung isn't getting much air, low PO2, the pulmonary arterioles supplying that area actually constrict. They redirect blood away from the poorly ventilated area towards areas that are getting plenty of oxygen.
Smart. Wasting blood flow on an area with no oxygen doesn't make sense.
Exactly. And conversely, if an area has high CO2 levels, the bronchioles leading to that area tend to dilate, allowing the CO2 to be flushed out more easily. It's a constant fine-tuning.
Okay, oxygen is now in the blood. How does it travel?
Almost all of it, about 98.5%, binds to hemoglobin molecules inside your red blood cells. Only a tiny 1.5% is dissolved directly in the plasma.
Hemoglobin, the oxygen carrier.
The primary one. Each hemoglobin molecule can bind up to 4 oxygen molecules. It's a reversible binding, picking up O2 in the lungs, forming oxyhemoglobin, and releasing it in the tissues, becoming deoxyhemoglobin.
And is it just a simple pick-up and drop-off, or is hemoglobin a bit smarter than that?
It's definitely smarter. Several factors influence how tightly hemoglobin holds on to oxygen. This is really important for delivering oxygen where it's needed most.
Like in active muscles.
Exactly. Things that happen in active tissues increase temperature, increase CO2 levels, increase acidity, lower pH due to CO2 and lactic acid, and increase levels of a substance called BPG inside red blood cells. All these things decrease hemoglobin's affinity for oxygen.
Meaning it lets go of oxygen more easily.
Precisely. This is called the Boyle effect. Hemoglobin effectively senses the metabolic activity of the tissue and unloads more oxygen there. It's incredibly efficient.
So even at rest, the blood going back to the lungs isn't totally drained of oxygen?
Not at all. Venous blood at rest is still about 75% saturated with oxygen. This is the venous reserve. A significant amount of oxygen still available if metabolic demands suddenly increase, like when you start exercising.
That's a crucial safety margin. What about problems with oxygen delivery? Hypoxia.
Hypoxia just means inadequate oxygen delivery to tissues. And one particularly dangerous type is caused by carbon monoxide, CO poisoning.
CO binds to hemoglobin too.
It binds to the same spot as oxygen, but it binds over 200 times more strongly. So even small amounts of CO can tie up a huge chunk of your hemoglobin, preventing it from carrying oxygen. And because it doesn't trigger breathlessness like low O2 or high CO2 does, it can be fatal without obvious warning signs.
Scary stuff. Okay, that's oxygen transport. What about getting the waste product, CO2, back to the lungs?
CO2 is transported in the blood in 3 forms. A little bit, maybe 7–10%, is just dissolved in the plasma.
Okay.
A bit more, around 20%, binds directly to hemoglobin, but to a different part than oxygen binds to, forming carbaminohemoglobin.
So hemoglobin carries both, but in different ways.
Yes. But the most important way, carrying about 70% of the CO2, is as bicarbonate ions, HCO3, dissolved in the plasma.
Bicarbonate? How does CO2 become bicarbonate?
This happens mainly inside the red blood cells. An enzyme called carbonic anhydrase very rapidly combines CO2 with water, H2O, to form carbonic acid, H2CO3.
Okay.
Carbonic acid is unstable and quickly dissociates into a hydrogen ion, H+, and a bicarbonate ion, HCO3. The bicarbonate then moves out of the red blood cell into the plasma for transport.
And something has to balance that charge moving out.
Right. As bicarbonate leaves the red blood cell, chloride ions, Cl, move in from the plasma to maintain electrical balance. This is called the chloride shift.
So most CO2 travels disguised as bicarbonate in the plasma.
That's the main route. And there's another effect too, the Haldane effect. Basically, hemoglobin that has released its oxygen can bind more CO2. So unloading oxygen in the tissues actually helps the blood pick up CO2, and picking up oxygen in the lungs helps unload CO2.
It all works together. In this CO2 transport, especially the bicarbonate part, is linked to blood pH, right?
Critically linked. That carbonic acid bicarbonate system is a major buffer system in your blood, resisting changes in pH. Because CO2 forms carbonic acid, your breathing rate directly influences your blood acidity.
How so?
Slow, shallow breathing lets CO2 build up, which forms more carbonic acid, lowering your blood pH, making it more acidic. Rapid, deep breathing blows off CO2 faster than it's produced, reducing carbonic acid and raising your blood pH, making it more alkaline. Your respiratory system is a powerful, fast-acting regulator of your body's acid-base balance.
Amazing how breathing connects to something like blood acidity.
Oh, yeah.
You've seen the parts, the mechanics, the chemistry. What's actually controlling it all? The brain.
Yes, the control centers are in the brainstem, specifically the medulla and the pons. Groups of neurons there, like the ventral respiratory group, ERG, are thought to generate the basic rhythm, that cycle of inspiration and expiration, about 12–16 breaths per minute at rest.
Setting the basic pace.
Right. And other centers, like in the pons, help smooth out the transitions between inhaling and exhaling.
But what signals tell these centers to speed up or slow down? What's the most important factor?
By far, the most important chemical factor controlling breathing in a healthy person is the level of carbon dioxide in the arterial blood.
CO2. Not oxygen?
Not primarily, no. Your body is much more sensitive to small changes in PCO2 than PO2. When PCO2 starts to rise, even slightly, it's detected by chemoreceptors in the brainstem.
And they tell the respiratory centers.
To increase the depth and rate of breathing. This ventilates the lungs more, flushing out the excess CO2 and bringing the levels back to normal. It's a very tightly regulated feedback loop.
So that's why holding your breath gets unbearable. The buildup of CO2 screams at your brain to breathe.
That's the main driver. And it's also why hyperventilating breathing too fast and deep can cause problems. You blow off too much CO2.
Leading to dizziness, tingling.
Right. Lowered CO2 constricts blood vessels to the brain. Breathing into a paper bag helps because you re-inhale some of that CO2, bringing levels back up.
Okay, so CO2 is king. When does oxygen become important?
Low oxygen, low PO2, only becomes a major stimulus for breathing when it drops substantially, usually below about 60 millimeter Hg. This is detected mainly by peripheral chemoreceptors in your major arteries, which then signal the brainstem.
So it's more of an emergency backup system for oxygen levels.
In a way, yes. Blood pH changes, whether from CO2 or other metabolic acids like lactic acid during heavy exercise, also influence breathing via those peripheral chemoreceptors.
And can we consciously control breathing? Or emotions affect it?
Absolutely. Higher brain centers play a role. Your hypothalamus links emotions and temperature to breathing, think gasping when scared or cold, and your cerebral cortex allows voluntary control, like holding your breath or changing your breathing pattern intentionally.
They're only up to a point.
Exactly. The brainstem's automatic controls, driven by CO2 levels, will always override your voluntary effort eventually. You can't hold your breath indefinitely.
Makes sense. What about adjustments for different demands, like exercise or altitude?
During exercise, your ventilation increases significantly to match the increased metabolic demand. This is called hyperpnea.
Is that the same as hyperventilation?
No, that's a key distinction. In hyperpnea during exercise, your breathing increases proportionally to keep blood O2 and CO2 levels remarkably stable. Hyperventilation is excessive breathing that does alter those levels, particularly lowering CO2.
What drives hyperpnea then, if not blood gas changes?
It seems to be a combination of things kicking in right at the start. Psychological factors, anticipating exercise, simultaneous activation of muscles and respiratory centers by the brain, and feedback from moving muscles and joints.
And at high altitude, the air is thinner.
Right, lower PO2. Initially, you might get acute mountain sickness headache, nausea, but over days or weeks, your body acclimatizes.
How?
Ventilation stays high. Your kidneys release erythropoietin, EPO, stimulating red blood cell production to carry more oxygen. And your red blood cells produce more BPG, which helps hemoglobin unload oxygen more readily to the tissues.
The body adapts. Amazing. But sometimes things go wrong. Let's briefly touch on some common lung diseases. COPD seems like a big one.
Chronic obstructive pulmonary disease, COPD, is a major cause of respiratory illness and death, strongly linked to smoking history, over 80% of cases. It's characterized by an irreversible decrease in the ability to force air out of the lungs.
Irreversible. And it includes different conditions.
Primarily emphysema and chronic bronchitis. In emphysema, the walls of the alveoli are destroyed, leading to larger air spaces but less surface area and, crucially, loss of lung elasticity. Exhaling becomes difficult, air gets trapped, and patients often use accessory muscles to breathe, sometimes developing a barrel chest.
And chronic bronchitis.
That's defined by chronic, excessive mucus production in the lower airways, along with inflammation and fibrosis. This obstructs airways, severely impairs gas exchange, and leads to frequent infections. These patients often have a cough and sputum production.
And asthma. It involves obstruction too, right?
Yes, but the key difference with asthma is that the obstruction is usually reversible. It's considered an inflammatory disease where airways become hypersensitive. Exposure to triggers causes inflammation, mucus production, and bronchospasm, constriction of airway smooth muscle, leading to wheezing, coughing, and shortness of breath. But between attacks, lung function can be relatively normal.
What about infections like tuberculosis?
Tuberculosis, TB, is an infectious disease caused by bacteria spread through the air. It typically affects the lungs, forming characteristic fibrous nodules called tubercles. It remains a huge global health problem, especially with the rise of drug-resistant strains.
And sadly, lung cancer.
Lung cancer is the leading cause of cancer death worldwide, and about 90% of cases are caused by smoking. It's particularly dangerous because it's aggressive and tends to metastasize, spread quickly. Smoking just overwhelms the lungs' defenses, damaging cells and allowing cancer to develop.
It really underscores how vital and how vulnerable this system is. It's just incredible thinking about the complexity, the constant work.
It really is. This nonstop interaction between your internal environment and the air around you, mostly happening completely without your conscious thought, just dedicated to keeping you alive breath by breath.
So, taking this deep dive, considering how connected your body's balance is to the air you breathe, what does that make you think about? Maybe the importance of air quality, or just the sheer unseen effort happening inside you right now.
It definitely gives you a new appreciation for something we take utterly for granted. What else might be going on inside, unseen, that keeps us going? It's fascinating to consider.